Welcome to the digital preceptor. So imagine your own airway cells acting like, well, like traitorous bouncers at a nightclub.
Right, the guys who are actually supposed to keep the trouble out.
Exactly. But instead of keeping the troublemakers out, they're actively sounding the alarm, unhooking the velvet rope, and, just letting the most destructive elements crash the party.
Yeah, and that molecular betrayal is essentially what happens in the airways of millions of people.
And understanding how to stop it is, it's going to be the key to passing your upcoming exams. We are your academic tutors, and we know you are staring down an absolute mountain of material right now.
Oh, for sure. Trying to figure out what actually matters for pulmonary medicine board exams can feel like, it feels like trying to drink from a fire hose.
Yeah, especially when you hit the constantly updating treatment guidelines, right? And of course, the incredibly dense immunology.
So our mission for this board review session is to shortcut your studying process. We are going straight for the highest yield concepts.
We're breaking down the pathophysiology, the diagnostic criteria, pharmacology, and the classic clinical presentations of asthma.
Right, along with the related hypersensitivity syndromes and essential pulmonary diagnostics. But the goal here isn't just rote memorization. We really want you to understand the underlying mechanisms.
Yeah, the why behind the disease.
Hmm.
Because when you are presented with a convoluted clinical vignette, and you will be, you need to confidently select the right answer and understand exactly the logic that gets you there.
Absolutely.
So before we get into the complex immunology of asthma, let's look at how the body's barrier defenses fail, because that is a recurring theme on the boards.
They love to test that.
Examiners frequently throw in a few high-yield diagnostic tests that deal with barrier dysfunction, either as the primary question or, as those annoying distractors.
Right, so let's start with the sweat glands and cystic fibrosis.
Okay, so pilocarpine iontophoresis is the gold standard diagnostic step. But how does this actually work mechanically on a patient?
Well, pilocarpine is a cholinergic parasympathomimetic agent.
Yeah.
So when it's applied to the skin, it essentially forces the sweat glands into overdrive.
Okay.
In a healthy individual, as that sweat travels up the duct toward the skin surface, the CFTR channel reabsorbs chloride, and sodium just naturally follows it.
So the sweat ends up relatively dilute.
Exactly. But in a patient with cystic fibrosis, that CFTR channel is defective, or it's just missing entirely, so the chloride cannot be reabsorbed.
It stays trapped in the duct.
Right, and it holds the sodium with it, which results in sweat with a highly elevated concentration of chloride.
And for the exam, you have to know the very specific numbers attached to this test. A chloride concentration of 60 millimoles per liter or greater is, well, it's diagnostic for CF.
Yeah. And on the flip side, less than 40 millimoles per liter makes the diagnosis highly unlikely.
But here's something that really trips a lot of test takers up. That intermediate gray area used to be 40 to 50 millimoles per liter. But recently, guidelines expanded that indeterminate range down to 30. So now it's 30 to 59.
Yeah, they did.
Why broaden the gray area if 60 is still the hard cutoff for a positive diagnosis? Like, what's the point?
It really comes down to the evolution of genetic testing. As we map the genome more thoroughly, we realized CF is not just, well, it's not a single monolithic disease caused exclusively by that classic delta F508 mutation.
Right. There are, what, hundreds of mutations?
Exactly, hundreds of CFTR mutations. And some of these create residual channel function, so the channel works just, very poorly.
So these patients might present later in life.
Yeah. They might present in their teens or 20s with recurrent pancreatitis or mild bronchiectasis rather than that classic childhood failure to thrive. And their sweat chloride might hover around 35 or 45.
Wow. Okay, so the old guidelines would have just misclassified them as negative.
Completely. By expanding the indeterminate range down to 30, we basically cast a wider net to catch these milder, atypical phenotypes.
That makes perfect clinical sense.
So if your patient falls into that 30 to 59 range, the next move on your exam is to order extensive CFTR genetic sequencing to confirm.
It's all about catching the outliers. Now, if we move from the barrier of the sweat glands to the barrier of the skin, we hit allergy testing. Examiners will always test your ability to distinguish between hypersensitivity types.
Always.
Type I is immediate, driven by IgE. So think anaphylaxis, hives, wheezing. Type 5e is delayed, driven by T cells like contact dermatitis.
Right.
So when we use intradermal skin testing, what is the actual clinical utility for board purposes?
Intradermal testing is utilized primarily for IgE-mediated type I drug allergies, like if you have a suspected penicillin allergy. And the board-relevant concept here is predictive value.
Okay, break that down.
Intradermal testing has incredibly high sensitivity. It is designed to be overly cautious. So if the test is negative, the negative predictive value is massive. You can be highly confident crossing that allergy off the patient's chart and giving them the drug.
But the trade-off for a test being that sensitive is that it's going to trigger false alarms.
Oh, absolutely. It is limited specificity. A positive intradermal test does not guarantee the patient will have a true systemic anaphylactic reaction.
Because it might just be local.
Exactly. You might just be seeing a localized histamine release that means nothing clinically. Patch testing, on the other hand, is a highly cost-effective, non-invasive option.
And we usually associate that with type 5e delayed reactions, right?
We do, but examiners might note that it's increasingly used for clinical phenotyping of some type I reactions as well.
Okay, let's talk about one more biomarker before we tackle asthma pathophysiology directly, and that's fractional exhaled nitric oxide, or FeNO. The boards love setting traps with this one.
They really do. Nitric oxide is a potent vasodilator. In the airways, it's produced by epithelial cells, specifically in response to interleukin-13, and by inflammatory cells like eosinophils.
Okay.
So when type 2 airway inflammation is raging, FeNO levels in the exhaled breath just spike. It is a fantastic, non-invasive window into the inflammatory state of the lungs.
So, I mean, it sounds like a perfect tool. If it measures inflammation, I assume I should use it to adjust my patient's daily asthma medications, but
Okay.
that is the trap, right?
That is the exact trap the examiners will set for you. It feels incredibly intuitive to use FeNO to titrate inhaled corticosteroids.
Right.
However, large clinical trials have consistently shown that tailoring long-term asthma therapy based on FeNO does not actually decrease exacerbations. It doesn't improve long-term clinical outcomes.
Oh, wow. So unlike measuring sputum eosinophils.
Exactly. Sputum eosinophils genuinely do guide effective therapy, but FeNO is easily confounded. It varies significantly across different ethnicities, and universal reference ranges just aren't standardized.
Okay, so you can use it as a snapshot of inflammation, maybe during a severe exacerbation. But if an exam question offers FeNO as the primary tool for long-term daily management algorithms, cross it out.
100%. Cross it out.
Good to know.
Yeah.
So that transition from barrier dysfunction and inflammation markers leads us straight to the ultimate inflammatory airway disease.
The big one.
The classic triad is episodic airway obstruction, airway hyperresponsiveness, and airway inflammation. But the boards often test the structural consequences of that chronic inflammation, right? The remodeling.
Yes, the architectural changes.
So what exactly happens to the architecture of the airway over time?
The continuous cycle of injury and attempted repair changes the tissue permanently. First, the smooth muscle layer undergoes both hypertrophy and hyperplasia.
Meaning it gets thicker and stronger.
Right. It becomes capable of crushing the airway shut with incredible force. You also see subepithelial collagen deposition, specifically repair-type collagens like tenascin and fibronectin,
Which thickens the basement membrane.
dramatically.
Mm.
And finally, the epithelium undergoes goblet cell metaplasia. It essentially transforms regular cells into mucus-producing factories.
Ugh, sounds awful.
It is. Over years, this stiffens the airway and can turn what was once a fully reversible obstruction into a fixed, permanent decline in lung function.
So to understand how to stop that remodeling, we have to look at the immune cascade. Let's go back to that nightclub analogy we started with.
Okay, let's do it.
Think of the airway epithelium as an exclusive, usually peaceful nightclub. When a trigger shows up like a virus, an allergen, pollution, it damages the epithelium. And the injured epithelial cells act like those rogue bouncers.
Right, they release cytokines called alarmins.
Yes. The big three alarmins to remember are TSLP, IL-kappa-5, and IL-33. These alarmins basically swing the doors wide open.
And then they immediately recruit the promoters of this destructive party, which are the type 2 innate lymphoid cells, or ILC2s, and the T helper 2, or Th2 cells.
And once these cells arrive, they start churning out a very specific cocktail of interleukins to drive the inflammation, right?
Exactly. The boards will specifically test you on the functions of IL-4, IL-5, and IL-13.
Okay, let's give you a memorable hook for these interleukins because they are the exact targets for the newest biologic drugs. First, IL-4. Think of the number 4 as the floor or the foundation.
The foundation of the allergic response.
Yep. IL-4 is the foundational signal that tells B cells to switch their production over to IgE antibodies. Without IL-4, you just don't get the IgE response.
That's a good one. Then we have IL-5. I like to say, think High five for the eosinophils.
High five. Nice.
IL-5 is the ultimate cheerleader for eosinophils. It stimulates their production in the bone marrow, recruits them to the lungs, and provides the crucial survival signal that prevents their programmed cell death, apoptosis.
So it basically keeps the eosinophils alive and active in the tissue.
Precisely.
Finally, IL-13. Think of this as unlucky 13. It's unlucky because it is the interleukin directly responsible for the miserable physical symptoms the patient actually feels.
The clinical presentation.
Exactly. IL-13 acts on the smooth muscle to cause that airway hyperresponsiveness, and it drives the goblet cell metaplasia we just talked about, which leads to massive mucus hypersecretion.
So that entire cascade, the alarmins, the Th2 cells, the interleukins, the eosinophils, all of that makes up type 2 inflammation.
Right.
But your exam will also expect you to recognize non-type 2 asthma. This is an entirely different biological pathway.
How so?
Well, instead of eosinophils, the dominant inflammatory cell is the neutrophil. And instead of IL-4 and IL-5, it is driven by IL-17 and IL-8.
Okay, so clinically, a patient with non-type 2 inflammation often has a history of atypical infections, like mycoplasma pneumonia, right? Or they might have a history of severe obesity or heavy smoking.
Exactly.
And the critical board takeaway here is that non-type 2 asthma is notoriously resistant to traditional inhaled corticosteroids. Giving them more and more steroid inhalers just won't fix a neutrophilic problem.
It's just going to cause side effects without any benefit.
Yeah.
So moving from the cellular level to the clinic, you have to prove this diagnosis on paper. Let's look at the pulmonary function testing criteria.
The dreaded PFTs.
You are looking for reversible airway obstruction. The strict definition of reversibility is an increase in the FEV1 of at least 10% after administering a short-acting bronchodilator.
Though keep in mind, many older exam questions still rely on the classic criteria, which is a 12% increase combined with an absolute volume increase of 200 milliliters.
Yeah, you still see that 12% and 200 milliliter rule all the time.
But asthma is episodic. What happens when your patient shows up to the pulmonary lab, they feel totally fine that day, and their baseline spirometry is completely normal? How do you prove they actually have asthma?
You have to provoke the airway to prove it's hyperreactive. You essentially induce a very mild, highly controlled asthma attack right there in the lab.
Sounds fine.
Oh yeah. The gold standard is the methacholine challenge. Methacholine is a cholinergic agonist that tells the smooth muscle to constrict.
Right, and every person's airways will eventually constrict if you give them enough of it.
True, but an asthmatic airway is twitchy. It reacts to a tiny dose. If the patient's FEV1 drops by 20% at a provocative dose, the PD20 of 400 micrograms or less, you have successfully demonstrated airway hyperreactivity.
Okay, so once you have the diagnosis, you have to write the prescription. And the guidelines for asthma pharmacology have undergone a massive paradigm shift recently.
Massive.
I really want to emphasize this because if you rely on old clinical habits, you will lose points on the boards. We used to think that a short-acting beta agonist, a SABA like albuterol, was the undisputed standalone rescue inhaler for anyone with asthma.
Yeah, but the Global Initiative for Asthma, or JANA, completely threw that old rule out. We now use the AIR strategy, the anti-inflammatory reliever.
Okay, what does that mean in practice?
The standard of care across all steps of asthma severity now relies on using a combination of an inhaled corticosteroid, an ICS, with formoterol as the primary rescue medication.
Wait, but formoterol is a long-acting beta agonist. It's a LABA. Why would you use a long-acting drug for immediate symptom relief? Why not something like salmeterol?
It has to do with the unique molecular properties of formoterol. While it is a LABA that lasts for 12 hours, it's highly lipophilic.
Ah, so it penetrates the cell membrane fast.
Incredibly fast. Its onset of action is within 1 to 3 minutes, making it just as fast as albuterol. It provides immediate bronchodilation while simultaneously providing long-lasting control.
But the real magic is pairing it with the inhaled corticosteroid. Think about what happens when a patient uses only albuterol. They feel tight, they take a puff, the smooth muscle relaxes, and they feel better.
But the underlying mucosal inflammation, the eosinophils, the swelling, is completely untouched.
Exactly. It is the equivalent of turning off a blaring fire alarm while the building is still actively burning. The patient feels a false sense of security while their airway remodeling just gets worse.
The data supports that entirely. Frequent SABA use without an ICS is strongly associated with an increased risk of severe, life-threatening exacerbations.
Wow.
By prescribing an ICS formoterol combination as the rescue inhaler, every single time the patient feels symptoms and reaches for relief, they are forced to inhale a microscopic dose of topical steroid.
They're treating the root cause inflammation concurrently with the symptom. That is brilliant. Now, speaking of labos, there is an absolute black box warning you must know for the exam.
Oh, this is a big one.
Long-acting beta-2 agonists must never, under any circumstances, be used as monotherapy for asthma. They must always be paired with an inhaled corticosteroid.
Right, because using a LABA alone in an asthmatic patient masks the inflammation so effectively that it leads to sudden catastrophic airway closure and significantly increases the risk of asthma-related death.
And examiners will try to trick you by mixing COPD guidelines, where LABA monotherapy actually is acceptable with asthma patients. Don't fall for it.
Never. Okay, so let's scale up to severe uncontrolled asthma. When patients fail high-dose inhalers, we turn to targeted biologic therapies. This is where your interleukins become testable therapeutic targets.
Right, those memory hooks from earlier.
Yep. If a patient's asthma is driven by severe environmental allergies, we can target the IgE antibodies directly with omalizumab.
So omalizumab binds to the FCC portion of free-floating IgE in the blood. It essentially handcuffs the IgE so it can never attach to the mast cells or basophils.
Exactly.
To prescribe this on a board question, the patient needs severe allergic asthma, a positive skin test to a perennial allergen, and a circulating IgE level generally of 30 IUML or higher. But what if the dominant problem isn't the IgE? What if the patient's blood is just teeming with the eosinophils?
Then you deploy the anti-IL-5 therapies. Remember, IL-5 is the high-5 survival signal for eosinophils.
Right.
Mepolizumab and reslizumab are monoclonal antibodies that bind directly to the IL-5 cytokine itself, neutralizing it in circulation.
Okay, but what about benralizumab?
Benralizumab takes a slightly different approach. It binds directly to the IL-5 receptor on the surface of the eosinophil. Not only does this block the survival signal, but it actually tags the eosinophil, recruiting natural killer cells to induce rapid apoptosis.
Wow, so these drugs essentially eradicate eosinophils from the airway.
They absolutely wipe them out.
Now, here is a pharmacological puzzle. IL-4 drives the IgE, and IL-13 drives the mucus and hyperresponsiveness. Do you have to give the patient two separate drugs to stop both pathways?
You don't, and it's because of a biological loophole. The receptors for both IL-4 and IL-13 share a common structural component, the alpha subunit.
Oh, nice.
Ducalumab is an ingenious biologic that binds specifically to that shared alpha subunit. By blocking that one critical piece of architecture, dupilumab simultaneously paralyzes both the IL-4 and IL-13 signaling pathways.
That is a highly effective two-for-one strike against type 2 inflammation.
It's incredible. And if you want to go even further upstream, back to our nightclub bouncers, you use tezepelumab. This drug binds directly to TSLP, one of the primary epithelial alarmins.
So by neutralizing the alarmin before it can even call for help, tezepelumab prevents the entire downstream inflammatory party from ever starting.
Precisely. To finish our review, let's pivot to the asthma variants and occupational mimics. These are highly standardized illness scripts that examiners expect you to recognize within the first few sentences of a vignette.
Yeah, these are classic buzzword territories. Let's look at AERD, or aspirin-exacerbated respiratory disease. It used to be called Samter's triad.
Right.
You are looking for a specific patient profile, usually an adult who suddenly develops severe asthma, has a history of chronic sinus infections with visible nasal polyps, and reports a severe, terrifying asthma attack shortly after taking ibuprofen or aspirin.
The mechanism here is an absolute favorite for examiners. NSAIs inhibit the cyclooxygenase 1 or COX-1 enzyme.
Okay.
In a normal patient, arachidonic acid is metabolized down two main highways, the COX pathway and the 5-lipoxygenase pathway. In AED patients, when you block the COX highway with an NSAID, all of that arachidonic acid traffic is shunted exclusively down the 5-lipoxygenase pathway.
Which leads to a massive, unregulated overproduction of cysteinoleucotrienes.
Yep, and those are profoundly potent bronchoconstrictors.
So, your therapeutic move is to block the leukotrienes. You use a leukotriene receptor antagonist like montelukast. And if the disease is severe, dupilumab is a fantastic option because it is FDA approved for both severe asthma and chronic rhinosinusitis with nasal polyposis.
Perfect. Next variant, ABPA, allergic bronchopulmonary aspergillosis.
How does that one usually present?
This typically presents in a patient who already has asthma or cystic fibrosis. Their airways become colonized by Aspergillus fumigatus, which is a common environmental fungus.
And the immune system just overreacts.
Massively. It mounts a destructive hypersensitivity reaction to the fungus. The board buzzwords to look for are central bronchiectasis on a CT scan, extreme peripheral eosinophilia, coughing up thick brownish mucus plugs, and a uniquely astronomical total serum IgE level, almost always over 1,000.
Over 1,000, wow.
Yeah, you treat the underlying inflammation with systemic corticosteroids and add an antifungal like itraconazole to reduce the fungal burden that's driving the reaction.
Makes sense. Now, contrast all of this with RDs, or reactive airway dysfunction syndrome. It looks like asthma, it acts like asthma, but the trigger is entirely different.
Right.
Typical occupational asthma develops slowly over months or years of low-level exposure to an antigen. RADS happens after one single catastrophic exposure to a massive concentration of an inhaled irritant like a chemical spill, a bleach accident, or toxic smoke. The irritant literally burns and strips the respiratory epithelium.
And because it is a direct chemical injury rather than an allergic immune response, the inflammation in RADS is heavily neutrophilic, not eosinophilic.
Oh, that's a key distinction.
It is. The hyperreactivity develops within 24 hours of the exposure and can persist for years, even though the patient is never exposed to the chemical again.
Fascinating. Okay, our final topic is hypersensitivity pneumonitis, or HP. This is a type 5e delayed hypersensitivity reaction deeper in the lung parenchyma caused by inhaling organic dusts.
And examiners absolutely love tying specific professions or hobbies to these reactions.
Yes, they do. Let's run through the classic clinical setups. I'll prompt you.
Okay, let's do it.
If a board question describes a worker who processes sugar cane and develops fever, cough, and dyspnea, what is the buzzword diagnosis?
The sugarcane exposure is the classic setup for bagasosis.
Nice. What if the vignette describes a farmer turning over moldy hay or working in a humid grain silo?
The antigen there is thermophilic actinomycetes, and the diagnosis is farmer's lung.
Okay, how about a patient who recently bought a parrot or maybe works breeding pigeons?
You're looking for a reaction to avian serum proteins found in the feathers and droppings. That is bird fancier's lung.
What about an industrial worker exposed to isocyanates while manufacturing polyurethane foam or spraying varnishes?
That is chemical worker's lung.
And finally, a patient who develops severe shortness of breath after regularly using an indoor jacuzzi or spa.
The exposure is contaminated water aerosolizing Mycobacterium avium complex, and the diagnosis is hot tub lung. Recognize the exposure, pair it with the interstitial infiltrates on imaging, and you have your diagnosis.
It's honestly incredible to look at how much precision is required to diagnose these different phenotypes today. But thinking about the future of this field is even more fascinating.
It really is. I mean, right now, our entire diagnostic model is fundamentally reactive. We wait for the airway to remodel, we wait for the FEV1 to drop, and we basically wait for the patient to suffer an exacerbation before we phenotype their disease and offer a biologic.
Right, which feels a little backwards.
Exactly. But the cutting edge of pulmonary medicine is moving toward polygenic risk scores. We are identifying specific genetic markers, like variations in the ORMDL3 gene, which are strongly associated with altered Th2 cytokine responses and severe early onset asthma.
So we could predict it before it happens.
Yes. In the near future, we may not wait for that first terrifying wheezing episode. We could sequence a child's genome at birth, identify their precise inflammatory endotype, and preemptively optimize their environment.
That's wild.
We might even deploy very low-dose targeted biologics to suppress the alarmin pathways before the clinical disease ever has a chance to manifest.
Moving from reactive inhalers to true predictive genetic medicine, that is the ultimate goal. Keep reviewing those inflammatory pathways, lock down your biologic targets, and remember why those guideline shifts happened. This is the Digital Preceptor Podcast, wishing good luck on your exams.